Providers, this is our video that we promised you about our limited use of long backboards. In Australia, they're calling them extrication boards, and that's because they use them to get people out of bad situations, and then they get them off as fast as they can. It's kind of old thinking, most of you know that, but backboards can be deleterious to medical care, can cause increased pain. They've shown to actually increase x-ray rates because it causes back pain on people, pressure sores, old people, or people with respiratory problems don't like to lay flat, it can impair their breathing. In penetrating trauma, long backboards have been shown to increase morbidity and mortality. So they are completely contraindicated in penetrating trauma in most systems, and that will be in our system as well. I want you to think of clearing somebody's lower back as you would the C-spine. Who do you put in a cervical collar? People with pain in their neck, midline tenderness particularly, any numbness or tingling to the arms, somebody with altered mentation, drunk, confused, head injury. Demented, I'm not completely convinced, is a considerable factor for altered mentation if they feel pain appropriately. So these are the people that you don't want to clear. Numbness to the arm, it's feeling like it's asleep. There are indications for putting them in the collar. Well, the lower spine is no different. If somebody has pain in their lower back, they have numbness in their legs, weakness in their legs, they're altered, they're drunk, they have an unreliable exam, then you should probably put them on a board and play it safe. There's a question of distracting injuries and the significance of that. My gut feeling would be if you have a significant long bone fracture or significant injury elsewhere, it's probably always safe to just put them on the backboard. Okay guys, continuing with the backboard implications, who do we put on and who do we not put on? Let's go over somebody we would not put on a backboard. Donna is our injured victim. I'm going to go up. Ma'am, are you feeling okay?
Yep.
I heard you were in a car accident. Does anything hurt you?
No.
Does your back hurt?
No.
Do you know where you're at right now?
Yes.
Can you tell me the date?
It's October 20th.
Good. Do you have any numbness in your legs?
No.
Tingling in your legs?
No.
Any weakness?
No.
Were you walking afterwards?
Yes.
Can you lift your leg up for me? Good. Can you lift your leg up here? Do your arms feel numb or weak?
No.
Can you make two fists for me? Do they feel strong? Does your neck hurt?
Nope.
How about your back?
No.
Roll over for me, please. Okay. Does that hurt back here?
Nope.
Okay. Do you want to try and stand for me?
Sure.
Good. Let's get you up here. There you go. There you go. So as you can see, the patient has no pain whatsoever. They could be in a rollover, but Donna is sober. She's coherent. Her legs are working, her arms are working. There's no numbness or tingling. There's no distracting injuries. There's no reason for us to put her on the backboard. However, had Donna had no back pain, but her neck hurts, and she's walking, we can put a collar on her and then put her on a cart. We don't have to put her on a backboard and immobilize her. Okay, additionally, the way you may want to look at it is who do you put on a backboard? And it's just kind of the opposites. What you want to worry about is somebody that may have discomfort, numbness or tingling, a deformity of their spine, or they're not conscious, or they're altered mentation or confused. So again, we're going to use Donna's example. Ma'am, I heard you were in a car accident today. How you feeling?
Okay.
Does anything hurt you?
No.
Okay. Any trouble breathing?
Nope.
Do you have any weakness in your legs, or do they feel numb?
I have numbness.
Which leg?
This one.
Does it feel like it's asleep?
Yep.
Okay, can you try and lift it for me here? No? Can you try this one? Okay. How about your arms? How do your arms feel?
My arms are fine.
Make two fists for me here. Good. Pull towards you. Push away. Good. Can you feel that okay?
Yep.
Can you feel your legs when I touch you?
Not bad.
Not that one, huh? How's your neck feel here?
Fine.
Good, okay. Man, we're going to get you on this board in a second, okay? If you review our protocol, there's indications for putting somebody on the board and indications for keeping somebody off the board. There is an age, I would say above 9, we can feel comfortable clearing. I don't feel that the age in terms of the elderly is as significant because I think an 80 or 90-year-old can tell you if they have pain or not. So I'm really not going to put an age limit on the upper end, but I would put an age limit to clear 9 and above. Anybody under 9, we probably should assume the worst and just bring them in immobilized for their safety. One other thing is, think about somebody walking at the scene. Even if they're slightly drunk or slightly altered, if you're walking, I can assure you your lumbar spine's working, and it's probably stable. So if somebody is walking at the scene, I think it's quite safe to put them on a cart. Now, if they're having neck pain or something like that, or really horrible back pain, or numbness or tingling, play it safe, put them on the backboard. But if they have minimal pain, they have no numbness, tingling, or weakness, and they're walking at the scene, I don't see a reason to put them on this extrication board.